Hi, we're going to talk about nephron protection in diabetic kidney. First, we have to talk about the definition. Uh, the kidney disease, the diabetic kidney disease is a critical determinant of death from cardiovascular causes in persons with diabetes mellitus. Beyond medication that control glycemia and blood pressure, only medication that inhibit the renin-angiotensin system, known as RAS, have had robust renoprotective effects in randomized controlled trials. The working unit of the kidney are individual nephrons. Each nephron is formed by a glomerulus, which filters fluid from the blood and a tubule system, which modifies the filtrated through the resorption of water and some solutes and the secretion of other solutes. In application in medicine, we're going to talk about more about the diabetes in the kidney disease. First of all, the diabetes initiates sodium glucose transporter 2, known as SGLT2 driven compromise of tubulo-glomerular feedback. This process directly delays the afferent arteriole and indirectly induces vasoconstriction of the efferent arteriole of the kidney. The result is an increase of both filtration pressures and glomerular filtration rate known as GFR. The renin-angiotensin system, known as RAS, inhibitions corrects the increased glomerular afterload but not the dilation of the afferent arteriole. And this problem can be corrected only through SGLT2 inhibition, which are the main pathway from treatment in this type of disease. This restores the tubulo-glomerular feedback, and both SGLT2 inhibition and RAS inhibition lower the glomerular filtration pressure, and this translates into long-term renoprotective effects. Note that calcium chloride sodium and NKCC2 sodium, potassium chloride transporter 2, and PGE2EN2 are involved in this process.
The kidneys play an important role in the body. They filter the blood, removing waste products and excess salt and water. If the kidneys become damaged, they falter in their task, causing fluid and waste to build up in your blood, leaving the blood polluted. Finding out that you have early diabetic kidney disease can alert you that your kidneys are in danger. It is important to take steps to protect your kidneys before the problem advances. People who develop diabetic kidney disease usually have no symptoms early on. Diabetic kidney diseases usually cause no symptoms until at least 75% of your kidneys' function is lost, and people who have the condition often produce normal amounts of urine. Doctors rely on tests that measure a protein called albumin level in the urine and blood tests to evaluate the level of kidney function. When the kidneys are working normally, they prevent protein from leaking into the urine, so finding protein in the urine is a sign that the kidneys are in trouble. You may be told that you have microalbuminuria or moderately increased albuminuria. That simply means that you have trace amounts of protein in your urine. Key complication of diabetic kidney disease is more advanced kidney disease called chronic kidney disease. This can progress, eventually leading to kidney failure and the need for dialysis or kidney transplantation. Treatment: keep your blood sugar in the right range, usually with hemoglobin A1C target below 7%. Keep your blood pressure below 130/80, especially if you have more than 300 mg of albumin in your urine per day. Doctors usually recommend specific types of blood pressure medicine for people who have diabetes and kidney diseases. Examples include ACE inhibitors and angiotensin II receptor blockers, also called ARBs, because they decrease the amount of protein in your urine and can prevent or slow the progression of diabetes-related kidney disease. Side effects include possible dry cough, allergy, and high potassium level. Your doctor needs to check your blood test a few weeks after starting either of these medications. Women who are pregnant or attempting to get pregnant should not take ACE inhibitors or angiotensin receptor blockers, as these can cause birth defects. Lifestyle changes can also help. Limit the amount of salt you eat, quit smoking, lose weight if you're overweight. Even small changes can make a difference. Get at least 30 minutes of exercise activity on most days of the week. Lower your cholesterol, eat less saturated fat. Avoid medicines called NSAIDs or anti-inflammatory medications such as ibuprofen or naproxen, as this can cause kidney damage. Call your doctor now or seek immediate medical care if you have new swelling, blood in your urine, much less urine than normal, or if you have no urine. Thank you for listening. If you like this video, please click the like button, hit subscribe, and ring the bell. Be healthier.
Then from pros and cons, we're going to talk about the pros and cons of the different treatments for this diabetic kidney disease. But first, we need to see a video about talking about more the diabetes in affecting the kidney.
Type 2 diabetes can lead to a number of complications, including kidney disease. Healthy kidneys play an important role, removing waste products from the blood. Inside the kidneys, millions of tiny blood vessels act as filters. Many substances are too big to pass through the filters, so remain in the bloodstream, while smaller substances, including some waste products, flow through the filters and become part of the urine. Kidney function helps to regulate the amount of fluids and salts in the body and control blood pressure. But with type 2 diabetes, the high levels of sugar circulating in the blood can damage the kidneys and compromise their function. Approximately 40% of patients with type 2 diabetes have established kidney disease. Patients begin to lose their kidney function, including their ability to filter out waste, medicines, and excess fluids from the body. The presence of protein in the urine can be an early sign of kidney disease. Symptoms of kidney disease may include swelling due to fluid retention, tiredness, insomnia, itchy skin, and nausea. Kidney disease progresses through different stages as the kidneys lose efficiency and waste materials build up in the body. It also increases the risk of hypoglycemia and type 2 diabetes complications, including cardiovascular disease. The last stage, kidney failure, usually requires treatment with dialysis or kidney transplantation. Many of the medications available to treat type 2 diabetes are predominantly removed from the body by the kidneys. Declining kidney function can affect that process. If the body can no longer filter medications out effectively, the risk of side effects may increase. It may also be necessary to adjust the dose of medication or change medications. As approximately 40% of people with type 2 diabetes have established kidney disease, it is important that healthcare professionals consider the kidneys and the impact they have on diabetes management.
Now for the pros, the renal protection that is achieved with RAS inhibitors and related to vasodilation of the renal arterioles. Because the RAS is highly activated in nearly all forms of chronic kidney disease, RAS inhibitors have nephroprotective effects not only in diabetic patients, but also in non-diabetic kidney disease. From cons, the inhibitions of glomerular feedback in diabetes persistently expose the delicate glomerular filtration barrier to an increased filtration pressure, which in patients with intraglomerular hypertension promotes the podotrauma and accelerates podocyte and nephron loss. The SGLT2 inhibition induces osmotic diuresis, which favorably affects body weight, blood pressure, heart failure, and cardiovascular outcomes. We're going to talk. Then the issue play in Ecuador. In Ecuador, diabetes is affecting the population with increasingly high rates. According to an Ensanud survey, the prevalence of diabetes in the population aged from 10 to 59 is 1.7%. The proportion goes up to after 30 years of age and 50, and 1 in 10 Ecuadorians already has diabetes. Unhealthy eating, physical inactivity, alcohol abuse, and cigarette smoking are the four risk factors directly related to non-communicable disease, including diabetes.
Janssen is looking at new therapies for diabetic kidney disease. We have some very interesting things in our pipeline. First, we have Invokana, or canagliflozin, which is a treatment currently approved for type 2 diabetes. The way that Invokana works is by allowing the body to excrete glucose through the kidneys in the urine. So this excretion of glucose leads to a decrease in blood glucose. It also leads to a mild diuresis and to a loss of calories. So you get a decrease in your blood, in your weight, and you get a decrease in your blood pressure due both to the diuresis and to the weight loss. And remembering that I said that controlling your blood sugar and your blood pressure are very important for preventing and treating diabetic kidney disease, these things are very good for the diabetic kidney. On top of that, there's also a mechanism called tubuloglomerular feedback, which is activated by this mechanism by which canagliflozin works. And there's some evidence to indicate that that may also be important in protecting the diabetic kidney. Currently, Janssen is running a phase 3 program. It's the only phase 3 program for this class of medicines, the SGLT2 inhibitors, looking specifically at diabetic kidney disease. And we're running a large trial in this phase 3 program, 3,700 patients, to test the hypothesis, and it is a hypothesis at this point, that treatment with an SGLT2 inhibitor, canagliflozin, can actually prevent the progression of diabetic kidney disease in those patients who already have it. SGLT2 is a pump in the kidney that is involved in resorbing glucose back into the body. When the blood is filtered by the kidney, glucose is freely filtered, and it would go right out into the urine stream if it weren't for the body's pumps that pump that glucose back in. This work is primarily done by two pumps, SGLT2 and SGLT1, sodium glucose cotransporter 2 and 1. And I list them in that order because that's the order they're actually found in the kidney. SGLT2 inhibitors block that pump's action and allow the body to excrete these filtered glucose molecules and therefore excrete excess glucose in the patient with diabetes. SGLT1 is still functioning downstream of SGLT2 when SGLT2 is blocked. SGLT1 is responsible for probably something in the range of 10% of glucose uptake. And so when you block SGLT2, you block the majority of the glucose uptake. And one of the nice features of SGLT2 inhibition is that there's a fairly low rate of hypoglycemia with this mechanism. And part of that low rate may actually be because you're not completely blocking all of the kidney's ability to take up glucose, but a large chunk of it.
And then, in conclusion, we have to understand the role of the kidneys in type 2 diabetes mellitus has taken on an increased importance in recent years with the arrival of sodium glucose cotransporter 2 inhibitors and anti-hyperglycemic agents, known as AHAs, that specifically target the kidneys. And this review includes an update of the physiology of the kidney and their role in the pathophysiology of the type to diabetes mellitus, and the mechanism implicated in the development of the progression of the diabetic kidneys disease, such as glomerular hyperfiltration and inflammation.